Good evening and welcome back to the fifth annual Men's Health Summit right here on blackdoctor.org. I'm your host this evening, Shamika Rhymes. Let me know in the chat where you are watching from. And remember to share this with your network because you never know who may need to know all about what we're talking about this evening or any of the other panels that we've gone through tonight. And if you have any questions at all tonight, make sure you drop it in the chat. So this is our third panel of the evening, and we're turning the spotlight to a subject that just doesn't always get the attention it deserves: prostate cancer in Black men. So we're diving into what prostate cancer actually is, the importance of early screening, and how we can better support our Black men through prevention, diagnosis, and treatment. So whether you're tuning in for yourself or someone you love, this is all about education, empowerment, and advocacy. So let me introduce you to tonight's panel. Tonight, we've got Dr. Abimbola Ayan Basan. I knew I was going to mess this up. He's a Houston-based urologist with a deep focus on prostate cancer and racial disparities in diagnosis. Welcome, Dr. A.
Hold on. Can you hear me? Thank you for
Yes,
having
I
me.
can hear you now. There you go. We've got Dr. Howard Sandler, a radiation oncologist from Cedars-Sinai Medical Center, and he's got a long track record of treating prostate cancer. Welcome, Dr. Sandler.
Yeah, thanks. Happy to be here.
Thank you for joining us. And to round out the panel, we've got Dr. Joffrey Mount Varner. He's an emergency room physician, author, and he also had prostate cancer. He's a survivor, and he's here to share both clinical insight and his personal story. So welcome.
Thanks for having me.
Thank you. So again, everyone in the chat, please drop your questions and I will get to those as we go along tonight. So I'm going to start with you, Dr. A. Can you explain what prostate cancer is and how it affects the body?
Yeah, absolutely. So prostate cancer, as with everything, is a malignant growth for the prostate gland. And to kind of get that better understanding, you kind of have to understand the function of the prostate. It's important in, semen production. And its way in action in body is usually a question of how do I know when I have the symptoms for prostate cancer? And I think that's where the early screening, and which is kind of the purpose of this discussion, comes into play. You don't typically have symptoms when it comes to the idea of prostate cancer. It's just one of those things where, fortunately, through research, we've been able to identify some biomarkers, and even PSA, which is a prostate-specific antigen, is perhaps one of the unique tests that we're still using to today, even though it's not the most perfect test. It kind of alludes you to like, okay, why is it high? Based on research, there's a certain number. So 0 to 4 is considered normal, but then oftentimes I get folks that tell me, oh yeah, my PCP got it and it's normal. So normal for a 55-year-old versus a 75-year-old is not necessarily the same. So I think that's where it's not very one size fit all or black or white, like you either have prostate cancer or you don't, but there's a variation in terms of what it means to have prostate cancer, what it means to have low risk, what it means to have high risk, et cetera. So very broad topic to begin with, and even within the academics and university setting, a lot of ongoing research right now. So prostate cancer, in definition, is just cancer of the prostate gland, and we're trying to do our best to try to emphasize the idea of screening, given the lack of early onset symptom presentation.
Thank you. And you answered my next question, which was, are there any early signs or symptoms? It sounds like there are none.
No. I think, unfortunately, when you start having symptoms, it's hopefully more in line with an enlarged prostate versus a advanced prostate disease So it's when I have patients coming in elevated PSA, that on its own doesn't define prostate cancer, right? So you just probably heard me talking about PSA being a screening test. You can have an enlarged prostate, which is basically something that grows with age in every male, and that could be it. And your PSA can be high secondary to that, but at the same time, you have to make sure you rule out what's more concerning, and which is the idea of prostate cancer, given the PSA numbers. So very, very nuanced in terms of how do you manage a patient that comes in with an elevated PSA, which is usually the initial kind of diagnostic referral from the PCP.
Okay. Now, I want to throw this question out to all of you, and whoever wants to answer first, feel free. But why is it so important for us to have this conversation specifically about prostate cancer in Black men? Why is it so important for that, this conversation? Is it that it's more prevalent in Black men? Why is this conversation so important?
Yeah, I guess I could start, and I'm sure everyone has a good response to this. But prostate cancer, in fact, is more common in Black men, and it, besides being more common in Black men, it tends to present with more advanced cancer when it is detected in Black men. So those two things are both true: more common and more advanced. And maybe we'll get into this, but the reasons for why it's more common, I think, still remain to be elucidated. But that's part of the reason that we're talking about this today. And related to what Dr. A said before, it impacts recommendations for how men should be screened for prostate cancer.
Thank you.
And then there's literature coming out of Hopkins that basically says, yes, Black men, they have more prostate cancer. But if you narrow it down more, Blacks, Western Africans have more prostate cancer than anyone. So they're still trying to tease that out. As it relates to symptoms, there are symptoms. I think what Dr. A was saying, that you may not have symptoms, but if you have increased urination, if you have increased frequency, the symptoms, if you have blood in your urine, the symptoms are many. That could be a sign. Now, just because you have those symptoms does not mean you have prostate cancer. And I'm sure that Dr. A and Dr. Chandler will get into this later. While it doesn't happen too often, you can have a normal PSA, which is the screening test. That's the main screening test that we generally use. You can have a normal PSA and still have prostate cancer. And that's when it gets very nuanced in terms about how you go about getting it worked up.
Okay, thank you. Dr. A, did you want to weigh in on this question as well?
Yeah, no, absolutely. I think I was born and raised in Nigeria, so being of West African upbringing myself, not necessarily something that you hear about per se. And then, growing slowly and then maturing and learning more about prostate cancer. It's more or less me advocating, telling family members, yeah, it's probably not what you want to hear, but it's better to know now than to bury your head in the sand and hope, So I think for me, at least, it's often always a sad story when I hear about metastatic or advanced prostate cancer, because it's such a thing that if caught early and acted upon, no one should be having mortality from, I don't want to be that extreme, but it shouldn't be such a late discovery. And again, there's more to be said about just get the first step, see what it says, because one number doesn't really define, prostate cancer. There's multiple things that's been implemented right now, and it's been acted upon to improve prior knee-jerk reaction to do biopsies, et cetera. So as much as it is, African tradition, it's oh, don't worry, I know an uncle who had it, nothing happened. And it's well, you don't know the whole story. Yeah.
And host Rhymes, let me just chime in here. I think he said a very major point, almost dropped the mic. And that is, if caught early, it's almost, not quite, but close to 100% curable. And so that's what this show is about, making sure you get screened. If you catch it early, and Black men, you should probably be screened earlier. And depending on what system you're in, you may need to be more aggressive about what is done if your PSA is actually elevated.
Well, Dr. Joffrey, so I was coming to you next because I wanted to hear your personal story, how you were initially diagnosed or misdiagnosed, and what helped you push for more answers. I mean, of course, you're a doctor, so maybe that was part of the reason you're well, let's take another look at this. So can you tell us your story?
Well, I thank you for that, for that setup. But often patients think that just because we don't catch it, it was missed, when perhaps we just don't have the technology. I was diagnosed at 56. I am quite sure that when I started seeing the urologist at 34, because I started having symptoms, it was probably present then, but we didn't have the technology. My initial biopsy, the first one, was negative. And so someone would say, well, the doctor missed it. No, the doctor didn't miss anything. It's just that it's a procedure done by a provider. It did not pick it up. It was only due, which is why you've got to be thankful for when things happen to you. A few months after that, I had a hernia. And as part of that hernia, you've got to get that pre-op done. A colleague was a surgeon, and so he gave me the lab. She said, let me check that PSA on my own. And it was elevated. And from then, that was, again, 3 months after the normal biopsy. And from then on, we were down the prostate cancer road. So in summary, to your listening audience, just because it's not picked up does not mean the doctor did anything wrong.
Thank you for that. Thank you for that. Because I think that sometimes that point is missed. And we have talked a lot just on this, not just with this panel or other panels, but just in general about misdiagnosis. So I think it's a clear difference between the two. Yes, and I see some. Well, I'll get to the questions in the chat in just a moment. I want to get a little further along in the conversation. But Dr. A, can you tell us, what does that screening process involve, and is it painful or invasive? Because I know I've heard men say, nope, I don't want to do it.
Right. No, I think, it's a lot of, I'll back up and say, just with the current, former President Biden, I've had a lot of patients coming in asking for the screening. So there's an essence and benefit for like just talking about it in general. But nobody wants to do anything related to prostate, like just the idea of just the basic DRE, which is often touted as you go to the urologist, you're getting that regardless of whether you're going in for, which is, TV shows, etc. So there's always that delicacy involved. We're talking about just, everything related to the male gender, sexual dysfunction, elevated PSA, prostate. So when it comes to prostate cancer, there's just been, I guess this is something that would hopefully diffuse some of the misconception, because it's kind of, I heard you're gonna probe something, and just me trying to counsel them and telling them, well, first thing, we just have to check the PSA. Then we have to repeat the PSA, because one number is not going to be the end all be all. And then luckily there have been ongoing researches to kind of like emphasize the idea of like using biomarkers. So I think more helpful will be my kind of somewhat of a pathway. I get someone who comes in with elevated PSA, and then I clearly ask them what's going on. Are you having urinary issues? Is it UTI? There are certain things that even as an early on resident, you learn can elevate your PSA. If you just had sexual intercourse, elevated PSA can be there. If you ride a bike, elevated PSA can be there. If you have a UTI, that can be slightly elevated. So we try to address that and emphasize the idea of like multiple data points is better than just one single high PSA. So after kind of getting that out there, we repeat the PSA. If it's elevated and the repeat is elevated and there's still some trepidation with the patient, which is it takes a lot of convincing to have someone say, yeah, we're going to do a biopsy. Okay. So we do, and this is just in particular to my clinic workflow, I get a 4K score. And that's a little bit more comprehensive in the sense of you don't just check the PSA, you check the PSA. And it also talks about what's called free PSA, and then the percent differences between that. And then in addition to that, the 4K tries to do a good job talking about your likelihood of having clinically relevant prostate cancer. So yes, you can have prostate cancer, but maybe it's the one that you just watch. But the 4K tells you, okay, clinically relevant, you have this percentage of having that. So with that number, I just go over it and I tell them in layman's term, well, 50%, that's your risk of having it. But I also emphasize that that's just the calculation. It's not definitive in terms of you have prostate cancer. And then other things that come into play is MRI imaging. So prostate MRI helps in terms of, okay, there's still question as to whether or not we should go with a biopsy. I typically would choose either the 4K score or the MRI. I don't do both unless there's still some equivocal findings. So if the 4K is high, that's a good enough reason to go ahead and get a biopsy done. If it's missed, or as Dr. Joffrey said earlier, if it's negative, then we have two things that I usually actually do. It's a secondary biomarker test called Confirm MDX, and that's basically saying, okay, how truly negative is what my negative biopsy shows, all right? And then that goes into like the DNA methylation. And the way I explain it to a patient is you've got an apple, something is going bad somewhere, you don't know, but we have a template that we use to biopsy. If we miss it, then whatever is going on is really, really tiny, which is fine. We're on top of this. If it gets out of hand, we're going to catch it. Like, that's the whole point of screening. And then the Confirm MDX tells us, okay, of the biopsy sample, is there any area that's concerned for DNA methylation that could be underlying biology for, cancer genesis? So that, if that comes back negative, the biopsy is negative, I tell them, well, just rest easy. We've done everything. All right. June 2025, you had elevated PSA, you got it worked up. It's negative. Don't worry too much about it. Your PSA is high. We can repeat it again in 3 to 6 months, and so on and so forth. So that was just kind of like from walking in, trying to get a PSA, to eventually getting the biopsy, to eventually discussing what the biopsy, in this case, negative biopsy, would imply. So, and from just briefly talking, it kind of tells you the nuance in terms of how patients' comfortability is. And I know like a lot of the guideline talks about shared decision making. No longer is the day the doctor says, well, you know what I think you need, you get this, end of story. So there's an input from the shared decision making with the patient. And there's a quality of life aspect to it too. So some patient will tell you, nah, I'm not doing none of that. I'm not doing no radiation. I'm not doing surgery. My sexual health is important, and I want to enjoy the rest of my life, So it varies, and I'm a little bit more maybe exaggerating in terms of the references from patient, but you do get folks who just come in and say, well, okay, good to know. Well, thank you. I'm not doing anything.
Mm-hmm. Yeah. Wow. Well, Dr. Sandler, when do they come see you? At what point?
Usually they come to see me after someone like Dr. A, urologist, has biopsied the prostate and identified prostate cancer. And it turns out that there's more than one way to manage prostate cancer. Mm-hmm. And surgery and radiation are the two most commonly used ways in the US. And many patients have both radiation and surgery as potential options. So as part of good multidisciplinary medicine, a lot of prostate cancer patients see a urologist and see a radiation oncologist to have a discussion about their options. And so that's when I get involved, Shamika.
Okay, thank you. Well, Dr. Joffrey, what treatment option, I'm in your business again, what treatment options did you have? Can you walk us through what that looked like for you?
I can, and so I'm gonna put on a full patient hat here, because what I found is that it gets confusing when you get into the weeds of it. Mm-hmm. I appreciate Dr. Sandler said that those are only two options, but then it becomes very, very nuanced. And I do want to make this point for anyone who's going to be diagnosed with prostate cancer, or who's dealing with it, or who's trying to make up their mind. So yes, surgery is an option. It has been my experience, because I do work at a VA as well. So I take care of a lot of vets, and I will even draw a PSA for them. But for men, the first thing that they think about is the surgery, and therefore I'm going to experience erectile dysfunction. And Dr. A, you can jump in here. When I was going through it, what was most important that someone explained to me was that, in fact, it was a Black urologist. He said, let me ask you a question, son. Do you have more sex in front of you or more sex behind you? And I thought that was a profound question. And then the second thing that he explained was, he says, how is your erectile function now? I said it. He says, well, if you have the robotic surgery, and that's what I want everyone to listen to, the robotic surgery with nerve sparing, it's very likely that like your sexual function is going to be what it was. If not, they can supplement it with say Viagra. But if you have an open prostate surgery, that's when you run into the impotence issues. And then, as Dr. Sandler said, you can get the surgery and radiation. But once you get the radiation, surgery is not an option. Then there's proton pump therapy. Then you get down the line, it's chemo. I don't say that to confuse people. I say that to let people know it's okay. It gets confusing, and that's why you want a urologist and a radiation oncologist who you like. I know it seems soft, but the reason for that is because you start having very intimate conversations. And so if you decide that this person does not have my best interest in mind, most people on your show, most people listening, have insurance. Get a second opinion, because them liking you and you liking them plays a role in your outcome, because the more confidence you have in what they're doing, you're going to have a better outcome.
Can I just jump in for a second?
Absolutely.
So the decision-making process can get complicated, and I was just trying to keep it simple when I said surgery and radiation. There's plenty of nuance, and extended discussions do occur. But I do think that prostate cancer is different than other cancers because it has kind of a naturally slow-growing tendency. It allows men to take whatever time they need to have multiple discussions, see different doctors. Maybe they like their first doctor and they go ahead, which is fine. But if they feel the need to investigate multiple options, men shouldn't feel pressured by the cancer to make a premature decision about their care. This is a big decision to make. Take the time, do your homework, so to speak, talk to friends, family, physicians, and then make the decision.
Can you give us a little bit more into what radiation looks like for this, Dr. Sandler?
Sure. Again, radiation encompasses lots of different options. In the US today, the most common way that men get radiation is what's called with external beam radiation. It's a beam that comes from outside the body. It's a relatively straightforward process. People, aren't familiar with it, so it sounds weird that they might be getting radiation as a treatment for cancer. But the process itself is very focused. The radiation beam is delivered under careful management just to the area that needs to be treated. Often it's the whole prostate that gets treated with radiation. And the way radiation's been typically given is once a day, 5 days a week, for about 5 weeks would be typical in the US. There is a ultra short 5 treatment approach, 5 treatments total instead of 5 weeks of treatment. But it's a daily outpatient session done usually in the basement of a hospital or a clinic.
Okay, thank you for explaining that, because I think sometimes we hear radiation and we're like, wait, what does that mean? So thank you for giving that explanation.
Like many things in medicine, things can be harmful or beneficial, and it could be the same thing. And radiation is one of those.
Well, as we have been talking about the early screening, how often should Black men be screened for prostate cancer, and what age should they begin being screened? Dr. A?
Yep. Can you hear me?
Yes, now I can hear you.
Yeah. No, that's a lot of this is kind of outlined in several guidelines. So you can look at the NCCN, AUA, and there's a component of it talking about risk factors. So ballpark 50, you start with PSA screening. And I think more interesting is actually the end age, so before it's kind of like, okay, once you turn 75, and if you haven't had PSA, prostate cancer, don't check the PSA. And now you're getting to the point where a lot of men are living healthy enough and active enough well into their 80s. And it's kind of a question of, well, what do you do then? So I think that's the part where there's a shared decision making, and there's a calibration in terms of what PSA threshold are you inclined to use to trigger your biopsy. So that's kind of like the basics when it comes to it. But then in terms of risk factors, I think we've alluded, and more particularly in terms of our audience, African-American man, history of, dad with prostate cancer or brother with prostate cancer. And I think more importantly, which is something that I try to bring up, is, female family members with breast cancer. So there's a component of that that's kind of like, okay, anyone in the family with breast cancer, this is male health, but that's another risk factor that, thanks to research, has been shown, and even treatment options have been developed based on the BRCA genes that's kind of like involved in very much more advanced prostate cancer. So you kind of have that in the initial conversation. And based on that, you can triage and say, okay, well, maybe we start at 45, based on your history, based on your family history, based on the overall risk factor. And then the better thing you can do in terms of prostate cancer is just having several data points, so you can know when that off, like high PSA is a false positive, and then you can feel comfortable getting a repeat and then seeing how it normalizes. Because I've seen that where someone came in with prostatitis, not sure what's going on. PSA was 18, and it's like, well, you've had a PSA of 2.1 several times. Let's just give it some time and repeat, and then it normalized. So again, kind of going with the idea of, okay, one number doesn't just define like prostate cancer. And luckily, we've kind of gone to the idea of, well, let's take our time, let's figure out what's going on, and then proceed from there before just having everyone going to go biopsy, because that's not even risk-free, so that's it's not to keep rambling, but that's when it comes to like screening, that's kind of like how I look at it.
Okay. I do see a question, and I'm not even going to attempt to say her name, but the question is, how can a man know when he has a healthy prostate, and how to, I'm not sure what they mean by this, but how to establish and maintain, I guess, how to make sure your prostate stays healthy. So who wants to tackle that question?
I think that's also something that I get, which is kind of like an inverse or indirect way of phrasing, like, well, what can I do to make sure my PSA, like, my PSA number, what can I do to bring that number below 4? And from my, research so far, and my understanding, not much in terms of dietary. I think we hear about, supplements like saw palmetto, and I think that's more of if you have an anti-inflammatory like kind of aspect of things, that calms the prostate down. And you can take medications like finasteride, which cuts your PSA in half, but then in the back end, you're knowing that. And then when you check your PSA, if it's 2, you're knowing that it's 4. So there's kind of like a back and forth with it. And there's also a need for a general understanding that as you age, your prostate is going to get bigger and the PSA number is going to be slightly growing. And there's factors such as PSA velocity, PSA density, that kind of factors into like, you've got 100-gram prostate and your PSA is 6. Okay, maybe it's not prostate cancer when we've done everything else, but we still have to prioritize the idea of cancer so we don't miss it. So that's where it kind of gets into weeds of things, where maintaining a healthy PSA, again, screening. I think the more the better off you can kind of adjust to whatever new information you might get. Yeah.
Thank you. I want to remind everybody in the chat, if you have questions, please feel free. Dr. Joffrey, what was that emotional toll like for you dealing with prostate cancer? What was that like? Because I think sometimes we forget about that emotional aspect of it.
I think you're mute.
Oh, yep, you're mute. There you go.
Because as a provider, all of a sudden, every patient I had prostate cancer. I mean, it was odd during that period of time. I got a lot of prostate cancer patients. I think that it's different for everyone. I was one of those. I chose not to tell anybody for several weeks just so that I could deal with the emotions of it. Because once you have any cancer, once you tell your family, it changes them. And so I'm into religion and my spirit. So I needed my time to just deal with it and to grow. Now, what I will say is that my colleague, Dr. A, let's just say this time a year ago, I was straight Western medicine, nothing else. I still practice Western medicine. However, when you're first diagnosed, as Dr. Sandler said, while it's a slow growing cancer, when you're first told you've got prostate cancer and something needs to be done, you think you're dying. So you started looking and reading everything. As a result of reading everything, and even once I started treatment, I did see that in other countries, in other parts of the world, there are certain foods that they tout that reduce the risk that we don't do here in this country, such as now again, I want to be very clear, everybody. I am not saying take these foods to treat prostate cancer. That's not what I'm saying.
Mhm.
I'm saying that these foods have been shown to help reduce the risk. Cruciferous vegetables, like the broccolis, like cauliflower, tomatoes, it's the lycopenes in them, the berries, and the fatty 3 acids. They all play a unique and interesting role. And so what I would do is that if for any male who has prostate cancer or any male who has a prostate, I would start to eat and as if you could get it. Because what we do know is that 1 in 8 men are going to get it. And what we do know, as Dr. Sandler said, it's a slow growing cancer. So there's someone listening now who's not been diagnosed, and they may very well have it. And what you don't want to do is feed that cancer. Thus, you want to make sure that you change your diet where you tilt things in your favor.
Are there any lifestyle things aside from diet that can also help, to, like you said, tip it into your favor? Is there any that you may know of?
Absolutely. I talked about this. If I did a whole series on it, they can follow me on Instagram at Dr. Joffrey MPH. But believe it or not, sleep plays a very important role. Exercise, and whatever you do. Now I'm sure I'm sure that Dr. Sandler, Dr. A will probably agree with me on this. Smoking. Do not smoke. That uniquely plays a role as relates to like prostate cancer, and obesity is a risk factor for prostate cancer. So exercising, making sure you control your stress and eating the right foods help tilt things in your favor.
We just finished the high cholesterol panel a little bit ago, and it was like some of the similar things of sleep, diet, exercise, and reducing the stress. It's interesting how, as the night has gone on, those seem to be the big things that they need to be focused on. Dr. Sandler, Dr. A, do you want to weigh in on that as well?
Yeah, I spend a lot of time talking about fitness with my patients, and it seems to be a good factor for cancer outcomes. Of course, I'm a radiation oncologist. Most of my patients are cancer patients, so I'm mostly focused on cancer cure, cancer outcomes. And there's a fair amount of evidence that fit people. I have 2 patients, a fit one and a not fit one, that the odds slightly favor the fitter patient just doing well, having fewer complications and a higher cure rate. So I do talk about fitness quite a bit. I will say that maybe I kind of agree with Dr. A. It's hard to know exactly from rigorous scientific evidence that if you have prostate cancer and you change your diet to something different, that you can have a long-term impact on cancer control. But diet and causing prostate cancer seems to be related. Of course, diet's very complicated. Their diet is just a mixture of all different things. And I think it's clear that we would know if there was one particular item that was causative. So it's probably some complicated mixture. But we do know that prostate cancer is less common in some Asian countries. And when people from those countries move to the US, their children, because they grow up with a Western US type diet, have a higher risk of prostate cancer. Wow. So genetically, they're the same because they're the children of immigrants, but their diet is different. So it's tempting to argue that our Western diet is maybe causative, but I don't think we know that if you switch back to an Asian or non-Western diet that you can reverse cancer. It seems to be a little bit of a one-way street. Once you have it, it's hard to use dietary changes to undo it.
Well, let me say this. So I will agree. Reverse it, it's less likely, but to slow it down. What we do know is that for most cancers, glucose, sugar feeds it. And so you want to watch and limit the like sugar. What the data also shows is that glutamate, that's one of the amino acids, that's been shown to feed prostate cancer. And so while we don't have clear evidence, people need to understand that we're practicing medicine. A lot of what was true in the New England Journal of Medicine 25 years ago, it is no longer true. And so while we can't prove it, what I've learned is that I want to tilt things in my favor because science just hasn't learned some of the things that I think that other countries, and maybe because other countries, in fairness to us, other countries may not have as much technology, and so they try a different type of treatments.
Thank you. Dr. A, did you want to weigh in?
Yeah, no, I think what I try to emphasize for folks when they see me in clinic, when that question comes up, like, what do I need to do? And I just kind of broadly tell them, whatever you can do to help your cardiovascular health is going to be very helpful for your overall prostate health. And again, I think the idea of adipose tissue inflammation plays a role not just within prostate cancer, but also within kidney cancer, for example. So, and I try to say, healthy living helps with a healthy prostate, and I think perhaps what's not brought up here, Dr. Sandler was talking about fitness. One thing that I started thinking about is the folks that I see who have low testosterone, but then they're taking testosterone, and then PSA comes into mixture of it, and then that just stirs the whole pot, and I'm just like, okay, all right. So it tells you the reason for prostate cancer being a hot topic within just the big wigs in academic urology, and in common, community urology, where there's testosterone clinic, just T centers, and it's kind of like, okay, well, I don't know if they checked your PSA right before you started, but what are we really doing here, et cetera. So it can get a little bit murky real quickly if you're not careful.
Mm-hmm. Dr. Joffrey, you seem like you wanted to say something about the testosterone.
Oh no, he nailed it.
Okay.
Just to connect it to audiences, is that prostate cancer is a testosterone sensitive cancer. So the more testosterone that's in your body, the more likely, if you have prostate cancer, the more likely it is to grow. And speaking of testosterone, I think this is Dr. Sandler's. So when they do radiation, radiation oncologists may offer testosterone blocking medicine as well. Did you want to comment about that, Dr. Sandler?
Sure. As you said, prostate cancer is a testosterone-driven cancer. Testosterone stimulates cancer. So lowering testosterone levels in the blood with medication can be used in certain circumstances as an anti-cancer treatment. So lowering testosterone can be very powerful. And there's lots of good scientific studies. We have a really good database on when to use hormone therapy in men who are receiving radiation for prostate cancer. So sometimes we do it and sometimes we don't. Again, it gets to the nuances of the individual cancer. But it kind of circles back to that exercise thing, that if I do indeed ask a man to take this hormonal therapy to try to improve their cancer cure rate, that hormone therapy is an anti-fitness drug too, and can cause a loss of muscle mass. So it's another reason why baseline fitness, or even fitness during treatment, exercise during treatment, can be important.
Goodness, I'm learning a lot tonight. I knew nothing about prostate cancer. I've learned so much already. And it's like time has gone by. There is one question that I'm going to grab from the chat before I ask the last question. But let's see. They want to know more about the role of sleep that you mentioned, Dr. Joffrey.
It is connected to what Doctor said earlier, inflammation. So what we do know is that people should think that we have three different brains. We've got the central nervous system. Then we have our autonomic nervous system, that's fight and flight. And then our gastric area, it's our enteric nervous system. And so when we don't get enough sleep, it impacts our GI tract and therefore makes it more likely for you to experience inflammation throughout your body. And as Dr. A said, inflammation should be considered the precursor to many different types of cancer. So not getting enough sleep increases inflammation, and often does it through a hormone called cortisol, which is a stress hormone.
Mm-hmm. And I'm going to plug the sleep apnea panel we just did a little bit ago. Watch that one too, because you may want to get a sleep test as well. So as we wrap up, what advice, because as we've been talking about early getting screened, what advice would you give to any of the men watching who are hesitant or afraid to get tested? Dr. A, I'm going to start with you.
I think the best thing you can do for yourself is to do it now. I think rather than wait and second guess and wait to 2026, get yourself the benefit of seeing what it was in 2025, and you can go from there. I think you kind of I'll be honest, it's easier said than done. I'm not the one dealing with the trepidations of like, what if it's high? What if what if it's 3.9? What does that mean? It's not, so there can be some subtleties with it, but I think what should be reassuring is there's a lot of treatment options. We kind of already emphasized, you know, surgery, radiation, et cetera, but there's some in between, like kind of have an option for just you take partial prostate gland and not to even get to the weeds of it. And you can do active surveillance where it's kind of like, okay, well, we just watch. Maybe we do a PSA repeat in 3 months instead of 6 months. I think that concern becomes improved when you know the action plan. Like, okay, I met with the urologist, my PSA is 2 point something. I have nothing to worry about. And even more so, more updated in the AUA guideline, I believe it's a subtlety where if your PSA is a certain number, you can just do it every 2 years instead of annually, right? So I think that's where it's kind of, okay, get it and see where you are and kind of use that as a springboard to kind of navigate your overall health moving forward. But I can empathize with the person who's like, I don't know, man. I don't know,
Mm-hmm. Yeah, thank you. Dr. Sandler, what advice would you give to someone who's afraid to get tested?
Yeah, so just to reemphasize, we've kind of highlighted that individuals with a family history or Black men are at higher risk for prostate cancer. And because of that, recommendations of expert panels suggest that screening should be done earlier in those populations that are at higher risk. And it could be 45, 40. It's a young age to start thinking about prostate cancer. But I would suggest to a patient, if I was talking to them about whether to get screened or not, that knowledge is power, and that you will have the information that you will need to decide what's best for you. Getting a PSA test doesn't mean that you are automatically going to have prostate surgery and erectile dysfunction. It allows you to be well informed and then make an informed decision about what's best for you. The alternative is to lack the knowledge and lack the power, and then the individual becomes a little powerless and is just kind of subject to the whims of the cancer rather than being on top of it.
Mm-hmm.
I wasn't very articulate there, but sitting down with a patient one-on-one, I would encourage them to be a well-informed patient. And I think prostate cancer screening, starting at age 40 or 45, creates a well-informed patient.
Thank you. Dr. Joffrey, what advice would you give to someone who's afraid to get tested? And you mentioned backstage about your book. Is that book about your experience as well? Or can you tell us a little bit about that too?
So the book, thank you for that. So the book is called Fast Decisions, Think Fast, Be Bold, and Be Fearless. It's about decision making. However, it uses the intro is about what happened and all the different decisions that you had to make, because it's thousands of them, and that you need to keep making them so that in the end you have an answer. As relates to the advice that we're giving, especially uniquely to Black men, Kaiser just did a study and looked at Black men and primary care doctors, and even Black men within the same network, they were 46% less likely to see the same primary care doctor as their white peers. You say, well, why does it matter? Because it will be your primary care doctor who's ordering that PSA. And so you would prefer someone who knows you, but you have been armed with this presentation where at least and I agree with Dr. Sandler, 45 is about the time that you want to go in there asking for it. And then based upon that number, you decide how often you're going to like get it done. And not only do you want to ask for it, medicines change, things happen. Make sure you follow up. Don't just assume that I didn't hear from them, so therefore it's negative. No, make sure you follow up and make sure you find out what that number is. And then finally, Dr. A and Dr. Sandler said it well. Information is power. So just making sure that you know what your number is key. And I would encourage everyone, if you think you have prostate cancer, don't go off the show trying to read up on it because it gets confusing. That's why Dr. A is an expert. That's why Dr. Sandler's an expert. It gets too confusing. Just understand the basics. And if that PSA is elevated, doesn't mean you have prostate cancer. It means you now have to start working with these specialists to figure out what is going on.
Well, I want to thank you all for such a powerful and eye-opening discussion on prostate cancer. Judging by the comments, it has, just the explanations and answering the audience questions has gone a long way. I know, like I mentioned, I now understand a little bit more about it. And tonight's discussion is a reminder that knowing your numbers can also be knowledge is power, as we've been saying. So for more information about prostate cancer, you can also go to our website, blackdoctor.org, for articles over there. But don't go anywhere because the Men's Health Summit continues. The next panel is coming up, and we're going to be talking about mental health, how to protect and prioritize your mental wellness. And, if you missed the other conversations, you can still go back and watch those as well. But I will see you guys in just a few in the next panel at 9:00. So thank you again for joining us.
Thank you for having me.
Thank you all for having me. Yeah, this was great.